In this lecture on the respiratory system, we're going to look at acid-base balance, so how acids and bases are produced and how they're distributed and some of the effects that they have on our body, as well as starting to analyse some arterial blood gases, your ABGs. You also have VBGs, which are your venous blood gases. So these are the kind of things that practicing clinicians will have to be looking at and interpreting a lot. So if we're just looking, crudely speaking, if we look at the pH within your blood and your tissues, it really is in the range, the healthy range is somewhere between 7.35 and 7.45. So we say 7.4 because it's nice and easy. And if it goes below that, you get to an acidosis. And that can be either two causes. It can be respiratory, so something to do with the lungs, or it can be metabolic, so something to do with your metabolism. So you can have a respiratory acidosis or a metabolic acidosis. And anything below about pH of 6.8, 6.9 will lead to death, in particular if it's a rapid change. And then you've got your alkalosis. This is when your pH is above 7.45. And again, that can be respiratory, if it's to do with your lungs, or metabolic, if it's to do with metabolic processes in the body. And really anything above 7.8 or 7.9 really is leading to death again. Okay, so today we're first of all going to look at how carbon dioxide is transported in the blood itself. That's nice and easy, doesn't take long. Then we'll look at the effects of hypo and hyperventilation on your CO2 levels. We'll touch on what it does to oxygen levels as well, but it doesn't have a huge effect. And how the CO2 levels, how the CO2 influence the pH. And we'll then think about those causes of metabolic and respiratory acidosis and alkalosis, and what some of the body's compensatory mechanisms are. So how do they deal with it if you go into an acidosis or an alkalosis? So if we're looking at this little table, this is the oxygen that we talked about before, remembering roughly 3% is dissolved, 97% is bound to hemoglobin. And with carbon dioxide, it's a little bit more soluble in fluid, in water. So about 10% of it is physically dissolved. Don't really need to talk about that very much more, other than to say, as with dissolved oxygen, the amount of CO2 dissolved in the blood depends on the partial pressure of CO2. And as I said, it's more soluble than oxygen because about 10% of it is dissolved. You have 30% of it carried to hemoglobin, and you kind of may have worked that out anyway when we talked about things that cause the dissociation of oxygen from the hemoglobin. If you remember, CO2 binds to the globin portion, alters its shape, causes the oxygen to be released. So, of course, CO2 is being carried bound to hemoglobin. So about 30% of it is carried in that way. But the majority of it, about 60%, is carried as bicarbonate. So, as we've talked about the dissolved portion, and about 30% of it binds to hemoglobin, binding to the globin portion of the hemoglobin, to form carbamino hemoglobin itself. And so that's all we really need to say to it. But remember, CO2 binds to the globin, causes a conformational change, helping to release the O2 from the heme portion itself. But 60% of it is transported as bicarbonate. And how does that bicarbonate form? Well, the CO2, there are a couple of ways, but CO2 and water reacts to form carbonic acid, and that then further dissociates to form protons, your hydrogen ions, and your bicarbonate ions. This is actually a very, very rapid reaction in the blood, and you don't really see this intermediate very much because it's catalyzed by an enzyme called carbonic anhydrase. So the reaction proceeds very slowly in the plasma, and it's very rapid in your red blood cells because of this enzyme carbonic anhydrase. So really what you're seeing there is CO2 and water reacting to form protons and bicarbonate very, very quickly. And the carbonic anhydrase, it kind of speeds up the reaction about 5,000-fold or so. And so now this is going on in the red blood cells, remember? And so the bicarbonate diffuses out of those red blood cells and into the plasma. And the bicarbonate, as we'll know, is much more soluble than CO2, and hence it's a very efficient mechanism to transport CO2. So we're basically transporting CO2 dissolved in the blood as either CO2 itself, remember, about 10%, but also as bicarbonate, which is that 60% of it, and it's very, very soluble. So we're up to a review question already, nice and simple. So true or false for each of these? Carbon dioxide is transported in the blood, ... Each one's a true or false. Press pause, have a look, then we'll go through it. Okay, so number one, carbon dioxide is transported in the blood as bicarbonate ions. Yes, that's obviously true, about 60% if you remember right. Bound to plasma proteins? No, not to any significant degree. Directly dissolved? Yes, it's directly dissolved in the blood, about 10%. As a gas? Nope. And attached to the globin portion of hemoglobin. Yes, that's true. It's attached to the globin portion, not the heme part. Okay, nice and easy. Presume you got all of those right. I hope so, at least. So we're now going to think about the effects of hypoventilating, so that's breathing slower, and hyperventilating, being faster, on CO2 levels and their relationship with pH as well. Just remember, whenever you see the words hypo and hyper is always kind of less and hyper is always more. So hypothermia is cold, hyperthermia is hot, for example. Okay, let's go. So when we're thinking about it, we have to think about the hydrogen ion concentration. So hydrogen ions are the protons, and of course it's the protons that dictate the pH. So our plasma or our extracellular fluid pH is maintained in that 7.35 to 7.45 range, and it's a narrow vital range, somewhere between 6.8 and 6.9 up to nearly up to 8. And outside those ranges, you tend to die. And of course, if you're in the normal range and you have a rapid drop from 7.4 to, for sake of argument, 7, that may well kill you as well because it's such a rapid drop and your body hasn't got used to it. Whereas someone who's got this more chronic condition where the pH is a bit low, they may be able to get down to that lower or narrow, that smaller number, if you like, that smaller pH. But anyway, so the key point is 7.35 to 7.45 is normal and it's a narrow vital range. And the pH scale really was developed for convenience. So your pH, which is what we use to look at the acidity in the blood, of course, is minus log of the hydrogen ion concentration. And so a pH change of 1 reflects a 10-fold change in the hydrogen ion concentration. So if you went from 7.4 to 6.4, that would mean you had a 10-fold increase in the number of hydrogen ions. Hence why you're kind of going, oh yeah, that's why we can't get to too low a pH. You can't really live with a 10-fold increase in your hydrogen ion concentration. So here's the reaction that we've talked about already. So the reaction of carbon dioxide and water to form your protons and your bicarbonate ion. And so if your CO2 starts to build up, what happens to that pH, do you think? Well, as your CO2 builds up, as you might expect, the reaction proceeds to the right, so you get a buildup of these protons. And if you've got a buildup of these protons, of course, the pH starts to go down. So your pH reduces as the CO2 starts to build up. Okay, so hypercapnia. So this is excess carbon dioxide in our arterial blood. The main cause of this, if you think about it, when you get a buildup of CO2, if you breathe less, so it starts to accumulate. So that's in hypoventilation. So in other words, you have ventilation is inadequate to meet the metabolic needs for oxygen delivery, but more and also for carbon dioxide removal. So your carbon dioxide levels start to go up and your oxygen levels start to go down. And that leads to elevated production of these CO2 generated hydrogen ions, as we've talked about. So you've got lots more CO2, so it proceeds in this direction because you've got a CO2 buildup, so you get a buildup of your hydrogen ions. And if you're doing it through hypoventilation, you're getting an excess hydrogen ions and it's leading to an acidosis. And because it's to do with your lungs, this is your respiratory acidosis. Now, in most lung diseases, not all definitely, but in most lung diseases, CO2 accumulates whilst O2 is low because the oxygen and the CO2 exchange between the lungs and atmosphere are equally affected. Okay, but there are some diseases, lung diseases, where you get a greater effect, for example, on oxygen levels, because oxygen isn't quite as soluble, so can't diffuse through inflammatory material quite as easily, which is liquid-based. Okay, so it's water-based. So obviously it's harder for the oxygen to get through because it's less soluble than it is for the CO2 to get out. But generally, I want you to just think, generally you'll get an accumulation of CO2 and a decrease in the oxygen levels that you require. What about hypocapnia? So that's where below normal CO2 in the arterial blood. And as you'd expect, if you've got too little CO2, you may be hyperventilating, so blowing off lots of carbon dioxide. So in this case, the rate of ventilation is exceeding the body's metabolic needs for CO2 removal. So you can do this yourself. You could become hypocapnic right now. You could just start hyperventilating. You're starting to hyperventilate. You're therefore reducing the CO2 in your blood, so your arterial CO2 levels drop. You could hyperventilate voluntarily, as we've just talked about, but the more common causes really are things like anxiety, fever, but aspirin poisoning can cause it as well. And it leads to that decreased production of CO2-generated hydrogen ions. So you've got less CO2, so you've got less of these hydrogen ions, and therefore you get an alkalosis because your hydrogen ions have gone down, so therefore your pH has gone up. And because it's to do with your lungs, we're hyperventilating, we're thinking this is a respiratory alkalosis. Now, of course, if you're hyperventilating, of course, your alveolar PO2 will tend to increase a little bit during these hyperventilatory episodes. And therefore, your PO2 may slightly increase because of that hyperventilation. But because your hemoglobin is almost fully saturated anyway, you actually add, in real terms, very little oxygen to the blood. Because remember, you're 97% saturated already. So a bit of hyperventilating to increase that PO2 in there really isn't making a lot of difference to that saturation level. Okay, so that's the second part. And this is the third part. Now we're going to start thinking about the causes of metabolic and respiratory acidosis and alkalosis, and how the body compensates for that acidosis and alkalosis. What does it do to combat it? So when we're thinking about it, we need to think, what are metabolic acids and what are volatile acids, as they're also known? So volatile acids, we'll come to it in a second, but basically all acids produced in the body, I do apologize for that, in the body are metabolic, apart from carbonic acid, which is the sole volatile acid. Remember, it comes from CO2. So let's think about those metabolic acids. These are acids produced from sources other than carbon dioxide, and they're not excreted by the lungs. So they may be produced due to the incomplete metabolism of carbohydrates, fats, and proteins. And there are lots of examples. So you've got your lactic acids, for example, from anaerobic respiration. That tends to get reused by the body. You've got your keto acids, your ketones. So these are produced during starvation from acetyl-CoA and fatty acids. They can be removed in the urine. So type 1 diabetics may present with an acute ketoacidosis, for example, through the production of these ketones, and you smell it on their breath. You've then got your fatty acids and your amino acids, which are acids nonetheless, but a little bit weaker. You've got phosphoric acid that you might be taking in. That's a food additive, for example, in things like Coke, okay, and that's removed in urine. So Coke is very acidic, not particularly good for you. So there are lots of acids that we can take in or we can produce ourselves. But overall, the human body produces huge quantities of acidic products, and we have to deal with them. And like I said, one of those other acids is the volatile acids, and that's the one that's carbonic acid, which of course is produced from carbon dioxide. So carbon dioxide and water going through carbonic acid and hydrogen ions and bicarbonate. So we produce huge amounts of these acids. So how do we lose hydrogen ions? Well, remembering what's in your stomach. Your stomach has got hydrochloric acid in it, so you will lose hydrogen ions if you vomit. You can also lose hydrogen ions in the urine as well. And so if you're losing hydrogen ions, of course, then you will have less hydrogen, so you will become alkalotic because you're losing the hydrogen ions. How do we gain them? Well, we get them from carbon dioxide, of course, which is a huge amount of CO2 or carbonic acid. Metabolism leading to production of lactic acid, keto acids, fatty acids. And also you may get the loss of bicarbonate in diarrhea. So if you have bad diarrhea, you may lose large amounts of bicarbonate, and you might lose bicarbonate in the urine as well. So if you're, in essence, by losing the bicarbonate or by gaining the hydrogen ions, you're basically becoming acidotic. And remember, like we said, blood pH above pretty much 7.8 or below 6.8 is incompatible with life, as we've said before. So when you're looking at someone's report. So hopefully you'll have a little bit of a description, or you'll be seeing a patient, and you'll have some information in front of you rather than just a set of blood gases. But if you did just have a set of blood gases, you still have to be able to work out what is wrong with what is potentially wrong. So the things that you need to find out, is an individual acidotic or alkalotic? So do they have an acidosis or an alkalosis? And is it respiratory or is it metabolic in origin? So the first thing you do is you look at the pH, because that will tell you whether they're in an acidotic state or an alkalotic state. Just quickly in your heads, or shout out at me, what is the pH range, normal pH range? Boop, boop, boop. 7.35 to 7.45. Hopefully you got that. So you know that if it's below 7.35, they're in the acidotic range. And if they're above 7.45, you know they're in the alkalotic range. So that's really easy. But then you've got to work out, is this alkalosis or acidosis? Is this because it's of a respiratory issue, so something to do with the lungs? Or is it a metabolic issue? Or is it actually both? So remember, people don't necessarily just get one disease. They could have a respiratory acidosis and a metabolic alkalosis, for sake of argument, and that might pull the pH into the normal range. So you've got to bear that in mind. That's why you need to see a history and you need to see the patient, but you still need to be able to interpret things. So if the primary disturbance or the primary problem when you're looking at the CO2 values, the PCO2 that's measured in a blood gas analysis, if the primary disturbance that you're seeing is in the PCO2, then you can go, aha, it's a carbon dioxide issue, therefore it's to do with the lungs. So it's a respiratory disorder. Whereas if the primary disturbance is to do with bicarbonate, which is the other thing that we measure in the blood gases, then you'd be going, aha, it's a metabolic issue, because the bicarbonate is regenerated by the kidneys, etc., etc. So CO2 issue, respiratory, bicarbonate issue, metabolic. So that should be quite simple, you would think. So I've got a couple of patients down here in front of you, and I've shown you some values that have been measured. So here's patient 1, here's the analyte, bicarbonate, pH, PCO2. So in a blood gas, there'll often be oxygen amongst other things, but this is keeping it nice and simple for this particular moment. Here are our values that patient 1 had. Here is the normal range. So all I want you to tell me is it a metabolic acidosis, a metabolic alkalosis, a respiratory acidosis, a respiratory alkalosis? Well, one of the 4 anyway. And what are some of the more common causes that you can think of that particular condition? And then have a look at patient 2. So press pause initially, do the first one, and then we'll go through that, and then hopefully you'll understand it if you don't already, and we can do patient 2. So press pause. Okay, so what did we see here? Well, the first thing we look at is we look at the pH. And you can see, the pH is low, so they have an acidosis. So straight away, we know they've got an acidosis of some description. And then you go, right, let's have a look at the bicarbonate and the CO2. And we look at the CO2 and go, that's in the normal range. Okay. Oh, bicarbonate, that's a little bit low. Oh, that's not normal. And they've got an acidosis. So this must be a metabolic acidosis. Now, why has the bicarbonate gone down? Well, the bicarbonate has gone down, and we'll talk about it a little bit later, because the bicarbonate is buffering the hydrogen ions. So it's taking away the hydrogen ions, which means the bicarbonate levels have gone down. So that's a metabolic acidosis. Can you think of some of the potential causes of metabolic acidosis? So you might be thinking about ketoacidosis, a lactic acidosis, ethanol and methanol, they both cause it. Acid poisoning, of course. You may have excessive parenteral amino acids. Renal failure can lead to it, and diarrhea, of course, because diarrhea, you're losing bicarbonate, which means your acids build up. So you get your metabolic acidosis. What about the next one? Press pause and have a look. Okay, let's go through this. So what do you think it was? Well, look at the pH first. So the pH is high. So we're now going to be going, it's an alkalosis. So you know it's an alkalosis. Now we want to have a little look at the bicarbonate and the CO2. And this time we're going, bicarbonate looks normal. Ooh, the CO2 looks low. What's happening there then? Well, obviously they're blowing off CO2. So there's some form of hyperventilation. So they're blowing off the CO2. Remember, the CO2 generates hydrogen ions. So we've got less hydrogen ions. So therefore the pH goes up. So we've got a respiratory alkalosis. What are some of the causes of a respiratory alkalosis when we're thinking hyperventilation? You'd be thinking things like stress and anxiety, fever as well. So fever stimulates the respiratory centers, for example. There are lots of potential causes, let's think. So you might have a high altitude can lead to a hypoxia, such as anemia. Some pulmonary diseases, so embolisms and edema, can potentially lead to it as well. So there are lots of potential causes, but the ones you really want to be thinking about at this point, nice simple ones, things like stress, anxiety, fever, and then we've got that high altitude as well. Okay, very good. Let's carry on. Oh, we've got another two for you. I forgot these were coming. Patient 3 and patient 4. So same thing. Have a look at patient 3 first of all. Okay, so patient 3. pH is low, so we're going, right, acidosis. Now we look at CO2 and we're looking at the bicarbonate. Bicarbonate's normal. CO2 is high, so we've got a buildup of CO2, which means we've got an increase in the CO2 generated hydrogen ions, which is leading to a decreased pH. So we're going, it's a respiratory acidosis. So what might cause that? Hypoventilation. So you might have airway obstruction or constriction. Some anesthetics as well, they depress the respiratory centers. So other things that depress the respiratory centers, some tumors can do it, sedatives and your anesthetics, as we've already said. You may have weak respiratory muscles that can lead to hypoventilation. And like we said, we've got the airway constriction and obstructions as well. Okay. So let's have a think. Oh, so sorry, another one. So you might be thinking about chronic obstructive pulmonary disease. So bronchitis and emphysema, they often lead to respiratory acidosis as well. Okay, and these will all get covered when we think about respiratory diseases and disorders. So last patient, there's only one set of acidosis, alkalosis left, but still want you to work it out. So press pause and have a look. So we're looking pH, it's high. We're looking CO2 in the normal range. Bicarbonate is a bit high. So therefore the bicarbonate has gone up. So it's built up. And it's built up because it really doesn't have enough hydrogen ions to buffer. There's not enough hydrogen around, so the bicarbonate has gone up. And that means that the pH has gone up. So what we've got here, of course, is a metabolic alkalosis. Why might you get a metabolic alkalosis? Well, you might have vomited lots of hydrochloric acid out. So you've lost that acid, so you become alkalotic, and it's metabolic cause. Or you might, for example, be taking chronic antacid ingestion, which is basically you're taking in lots of bicarbonate to alleviate an acidosis. Acid release into the stomach causing issues. Acid reflux, for example. But the whole point is chronic antacid ingestion and vomiting can lead to your metabolic alkalosis. Okay, so now we know some of the causes, or at least some of the different ways we can get a metabolic or respiratory acidosis and alkalosis. But what does the body do about it? Do you just want to go into this acidotic or alkalotic state, or do you want to do something about it? Well, you clearly want to do something about it. So there are buffers, and these react very, very quickly. And we've actually looked at one of those. We looked at how bicarbonate was involved in the buffering of the hydrogen ions. And that's our major plasma buffer, is bicarbonate. And those values change because they're buffering those hydrogen ions. So other buffers include hemoglobin and various plasma proteins as well. But bicarbonate's the strongest. And you know hemoglobin's involved because we've already talked about how it binds to hydrogen ions. Then you have various compensatory mechanisms. So that's a buffer. Then you have compensation. And this is respiration. And this is very rapid as well. So you get respiratory compensation. And this is where you basically blow off carbon dioxide. And it compensates for metabolic disorders. So if you've got a metabolic acidosis, you blow off carbon dioxide to get rid of that excess CO2, which of course is formed because of the excess hydrogen. So it compensates for metabolic disorders. And then you've got the renal acid excretion or retention. That takes a bit longer. It can take days to kick in, so it's nowhere near as quick as the respiratory system. And the renal system starts to compensate for respiratory disorders, but it'll also compensate for metabolic disorders that don't involve the kidneys as well. So it can excrete more or less acid depending on the state that it's in. It can also regenerate bicarbonate, more or less bicarbonate as required as well. So that renal mechanism is quite powerful. but it takes quite a while to get going. And so the important thing to remember is these systems aren't correcting the initial problems. If you've got chronic obstructive pulmonary disease, it's not dealing with the chronic obstructive pulmonary disease, but it's helping to minimize the changes in pH that are occurring within your body so that you don't have the issues with proteins being misfolded or not working. As pH changes, proteins don't function as well because they're not quite as in their correct conformations. They're not as efficient, and your body's not working as well. So what is a buffer? So a buffer really is a mixture of substances. This is a bit of chemistry, everyone, and I'm rubbish at chemistry. So this is the level of chemistry you're going to get from me. A buffer is a mixture of substances in solution that resist changes in pH when you add small amounts of an acid or a base. And buffering is the first stage in maintaining normal acid-base balance to help keep that pH in range. So remember, when we're forming this bicarbonate is buffering hydrogen ions if you're in an acidotic state. And if you're in an acidotic state, the bicarbonate goes down because it's buffering these. So it's getting lower. If there isn't enough hydrogen ions, then the bicarbonate starts to go up if you're thinking about metabolic disorders. So bicarbonate, like I said, is that major extracellular buffer. So, for example, if you have a very high hydrogen ion concentration, bicarbonate binds to it, the reaction proceeds to the left, as you might expect. And so, so if you're thinking about an acidosis, you're getting that reaction going to the right. But in addition to that, this hydrogen ions also directly stimulates the respiratory center, leading to increased blowing off of carbon dioxide, which further drives the carbonic acid to the left to form more CO2. So if you have a metabolic acidosis, lots of hydrogen ions building up, reacts with the bicarbonate, pulling the reaction to the left, meaning the bicarbonate goes down. So it's pulled to the left. That CO2 is then blown off because it's stimulating the respiratory centers, but that hydrogen ion is also being stimulating the respiratory centers to blow off the CO2. So that's part of the compensatory mechanism. Remembering bicarbonate is regenerated by the kidneys and hydrogen excreted by the kidneys. And therefore we can regulate bicarbonate as well as hydrogen ions. Whew, chemistry, eh? So here are our mechanisms again. So we've got buffers, we've got respiratory compensation, and we've got metabolic compensation, or renal acid compensatory mechanisms. So renal compensation. When you have issues with the respiratory system, whether that's an acidosis or an alkalosis of respiratory origin, leading to these respiratory acidosis and alkalosis, the renal system compensates by excreting or preserving hydrogen ions as it needs, or by regenerating or excreting bicarbonate. But it does take time to respond. The respiratory system, so the renal compensate, just also to note, the renal system will also excrete and regenerate hydrogen and bicarbonate if it's a metabolic disorder, as long as it's not the renal system where the defect lies. So the renal compensation is basically helping to compensate for everything except if there's a renal issue, because obviously it can't do that. And you get respiratory compensation when problems arise with metabolism, so metabolic processes leading to a metabolic acidosis or alkalosis. The respiratory system compensates by excreting or preserving CO2, and that's much, much quicker. And as you might expect, the respiratory system cannot compensate if you have a respiratory issue, because your respiratory issue is there. So really what I'm going to do now, I'll quickly come back here. So some of that's a little bit complex, for me at least, the chemistry stuff. So I'm going to give you some examples for you to work out whether we're getting compensation or not, and what is the type of compensation. Basically, I'm going to give you 4 little practice cases that you've already seen. Or is it 2? No, it's 2 actually. I'm going to give you 2 little cases that you've already seen, and I'm going to ask you to tell me what compensation is potentially going on, and that'll hopefully bring it all together. So patient 1, here we got that acute presentation. Now, if you remember, this is the same patient that we had before. So this is the acute presentation. So really, I just want you to tell me what is the issue in this case. Respiratory, metabolic, acidosis, alkalosis. Press pause, have a look again. Don't remember and look back, work it out a second time. Okay, so you can see pH is low, so you know it's an acidosis. CO2 normal, bicarbonate low, so we've got an acidosis. The bicarbonate's dropped down because it's buffering hydrogen ions, and it's therefore a metabolic acidosis. Now, if you've got a metabolic disorder, what kicks in? So when a metabolic acidosis persists, the respiratory system kicks in, but also, depending on what the exact condition is, you may get renal compensation later on as well. So when the metabolic acidosis persists, the respiratory system responds by removing carbon dioxide. That's your respiratory compensation. That's your Kussmaul breathing. Okay. In other words, your Kussmaul breathing is acid-induced hyperventilation, where you get deep, laboured breathing associated with a metabolic acidosis. So you're starting to blow off CO2 with your metabolic acidosis. So just so you know, many of you, I'm sure, have had one or two too many beers or wines or vodkas in the night, and you wake up with a bit of a hangover the next day, and that next morning you will have a metabolic acidosis, and you may find yourself lying in bed, feeling rough, feeling sorry for yourself, and trying to blow off CO2 because you've got this metabolic acidosis. I still think back to the days when I used to lie hungover, going feeling rough, and actually I didn't know what I was doing when I was doing that deep breathing and blowing out, but I was actually removing carbon dioxide because of the metabolic acidosis I had. So there you go, something interesting for you to think about next time you're lying down with a hangover. Anyway, so 1 hour later, so we've got an acute change going on. Okay, so we haven't got this is a very rapid change that's kicking in. I now want you to look at the results that you see and tell me, with this patient, do they have an uncompensated metabolic acidosis, a fully compensated metabolic acidosis, or a partially compensated metabolic acidosis? And the tricky thing is, I'm not going to tell you how you can work it out yet. I want you to look at the values and tell me, is it uncompensated? Is it partially compensated? Or is it fully compensated? So press pause and have a good think about this. Okay, now we're going to have a little bit of a think about this. So which did you come up with? Uncompensated, fully compensated, or partially compensated metabolic acidosis? Now, hopefully, though I'm convinced that not all of you will have done, you have come up with a fully compensated metabolic acidosis. Why, you may ask yourself? Well, the reason is, the first question is, can you see any compensation? So remember, we had a metabolic acidosis. The bicarbonate is still low, as you would have expected, because it's a metabolic acidosis. And now if we look at the CO2 is also low. So why is that? Because there's hyperventilation. They've been blowing off CO2, meaning that the CO2, the partial pressure of CO2 in the blood, is now low. So we now know that there is definitely compensation going on. Okay, so it cannot be an uncompensated metabolic acidosis. So the question is, how do we know if it's fully compensated or partially compensated? It's very simple. It is a fully compensated metabolic acidosis if the pH is back in the normal range. And as we can see, the pH is back in the normal range. So the pH has been fully compensated. It's come back to normal. I mean, they've still got whatever condition they had, but the pH is now back in the normal range. So a partially compensated metabolic acidosis, that 21 would be the same for sake of argument, the 9 would be the same, but that might say 7.32. So it's not back in the normal range, but there is still compensation going on, so it would have been a partially compensated metabolic acidosis. Okay, have a quick look through it again if you're not sure, and you will get plenty of practice, don't worry. So next one, so this is our patient 3. Don't go back and look and see what patient 3 had. What have they got? Have a look at the values and tell me what they have. So hopefully you came up with that respiratory acidosis, because again, you can see 7.13. So we've got an acidosis, and the CO2 is very high. So we've got CO2 accumulating. So we have more CO2 generated hydrogen ions, and the bicarbonate in this case is in the normal range. Now, when a respiratory acidosis persists, the kidney responds by excreting hydrogen ions and making more bicarbonate. That's your renal compensation. Remember, that takes a little bit of time. It takes, maybe a day or two to kick in. unlike the respiratory compensation, which can be very rapid, as in our previous example, which was just 1 hour later. This is 48 hours later. So now I want you to tell me partially compensated, fully compensated, or uncompensated respiratory acidosis. Okay, let's have a look. So first of all, we'll just look at the CO2. You can see that's still high, so you've still got that respiratory acidosis there. This time you can see the bicarbonate has gone up, and that's because we're trying to generate more bicarbonate to buffer the CO2 generated hydrogen ions. So our bicarbonate is going up at this point because of that renal compensation. So we definitely know compensation is taking place, and the pH, well, it's not back in the normal range, so it's not fully compensated. So therefore we have a partially compensated respiratory acidosis. We are done, and I hope you enjoyed it. Ta-da!